Yeah, friends, greetings from the USICON Hall A. We are starting the technology session. The first talk is by Dr. Ananda Dhanasekar. Ananda is a urology consultant in the Birmingham Hospital NHS Trust. He also works as a tutor in the University of Edinburgh, and there he looks after the core urology curriculum. Ananda has interest in minimally invasive surgery for prostate, and the first talk he is going to deliver is on UroLift. So over to you, Ananda.
Thank you, Krishna.
Yeah, and he's the only guest lecturer who is physically present in the USICON.
Thank you.
Mike.
Thank you very much. First of all, thank you, USICON 2020, for inviting me, and thank you for the scientific panel for this opportunity. Thank you for the chairpersons. It's nice to see you all physically, face to face. I'm glad to see that after I landed in India, slowly the numbers are coming down. That's a good news, isn't it? So, I'm aware that UroLift is fairly a very new procedure for India, even though it is well established in America, UK and European countries, and especially in Australia also. So today I will try to introduce the procedure so that maybe late 2022, when the procedure is formally licensed, it will be a quite interesting one to start the training and practice. Today I will divide my talk into three main sessions. We will try to understand the UroLift patient selection criteria. We will try to understand the components of the UroLift delivery system, and also how we can perform under local anesthesia and various training opportunities available. It is mainly for the patients who are suffering from voiding LUTS due to BPH. Maximum size of the prostate acceptable is 100 cc, while if the prostate is thin and lean, possibly up to 110 cc, we can do UroLift comfortably. For example, EAU guidelines accepts till 70 cc, and NICE and AUA guidelines accepts up to 80 cc. So the size is quite variable depending upon the prostate's actual anatomy. The main contraindication is infection. As we all know, infection and implants will never go together. We need to make sure the patient is completely treated of UTI before placing the implant. This short video will give you a kind of a preamble for the talk.
Invasive technology designed to relieve urinary symptoms and improve quality of life with minimal side effects for men with an enlarged prostate caused by benign prostatic hyperplasia, or BPH. The UroLift system procedure begins by inserting an implant delivery device into the urethra. An attached endoscope provides visibility to the obstructed prostate. On reaching the area blocked by the enlarged prostate, the obstructive prostate tissue is moved aside. Following a trigger press, the device inserts a fine 19-gauge hollow needle across the prostate and deploys the implant through the needle. The implant is a nylon suture fixed in place with a thin metal tab at each end. Depending on the prostate size and blockage severity, the doctor inserts several more implants the same way. Typically, 4 to 6 implants are placed into the prostate. The outer capsule of the prostate is firm and provides a solid anchor, which allows the implants to lift and hold the enlarged prostate tissue out of the way so it no longer blocks the urethra. As the sutures are shorter than the prostate depth, the prostate laterally compresses. This reduces pressure on the urethra and provides immediate visible results so urine can flow freely. It's a mechanical solution to a mechanical problem. The minimally invasive procedure requires no cutting, heating, or tissue removal. This procedure avoids erectile and ejaculatory dysfunction. It typically also means minimal downtime, mild to moderate side effects, and a quick return to normal activity. The UroLift system provides a clinically proven treatment for those who suffer from an enlarged prostate that can get men off BPH medications and avoid major surgery.
So this is a very good understanding video so that you will know how the prostate is nicely opened up if the implants were placed in a correct position. How can we select the patients? Mainly we have three group of patients. Patients who are on watchful waiting without any medicines or not tolerating medicines. Patients who are on medicine but not much improvement. And patients who wish to have surgery and really try to avoid the TURP because of the side effects. AUA guidelines clearly says if a patient wishes to have surgical options at the same time wishes to preserve ejaculatory function and erectile function, UroLift is a good option. EAU guidelines approves UroLift up to 70 cc. This is one of the important slides. I consider that untreated prostate causes secondary changes in the bladder. I will correlate this with the metastasis of the prostate cancer. We always wish the prostate cancer to be treated in an organ confined manner. Nobody wish to have a lymph node or skeletal metastasis. Similarly, in benign condition also, we wish to treat the prostate before it gives any secondary changes in the bladder. If patients are untreated or patients are taking medications without knowing that they are passing urine in high pressure, it can cause significant irreversible changes in the bladder. These group of patients, even if they undergo TURP, they will always have some residual storage symptoms. This is what we need to avoid to make sure that a procedure is available in a very minimally invasive manner with less side effects. Why UroLift? UroLift gives rapid recovery. It's very durable symptom relief. It's an alternative to even medical treatment in the Western world. It is less invasive, preserves sexual function, and avoids complications of surgery like TURP or OLEP, especially if the gland is suitable in size. Once we introduce UroLift in India, the aim is to create a national database, and your individual results of IPSS score on an average will be plotted against the national historical study like LIFT study. So you can compare your results. If your results are better, you can take it as a good example for your practice. If the results are marginally on the negative side, we can find the techniques and fine-tune them to improve them further. You can see that the UroLift gives durable long-term results. As of now, the results are available up to 5 to 7 years, both in decrease in the symptom score and also improvement of quality of life. The improvement happens within first 1 or 2 months and sustains for a longer time. The durability of the result is not only due to the mere compression by the implant. The compression causes ischemia and atrophy. This is a sterile atrophy, unlike the atrophy caused due to the other energy sources like resume or previous TUNA needle ablation, where the atrophy is not sterile. Here, because of the sterile atrophy, the gland undergoes apoptosis, and that apoptosis is durable and works for the longer years. How will you select a patient? It is advisable to do flexible cystoscopy before selecting a patient for UroLift, at least during the initial stages. That is the only way you can measure the median lobe. Based upon the size of the median lobe, you can tailor your techniques. Once you get enough proficiency, maybe after 20 to 30 patients, you can avoid flexible cystoscopy in the day-to-day practice. I am sure most of you perform ultrasound before even TURP. Ultrasound is a good tool to measure the intravesical enlargement of the median lobe, and also it gives the height to width prostate dimensions, which is very useful when you are planning for your implant insertion. So best practice is to document the intravesical enlargement size and AUA scores and other parameters. Now let us see the pre and post look. For example, this is a 60 ml gland. There is not much of median lobe, but you can see that the gland is quite fleshy and also very vascular. The gland is kissing all the way from the bladder neck up to the veru. These patients will require up to 4 implants, 2 on either side. I will show the implant delivery in the future slides, but now you can see the post-implant insertion. As usual, because of the implant, the picture is a bit bloody, but the implants are nicely opening up the glands. And also, as we come back, you can see that the whole kissing lobe is nicely opened up. We are using normal saline irrigation, and from the veru you can see that the opening is nicely mentioned. This is an example for an obstructive median lobe, and this kind of obstructive median lobe will need at least one extra implant so that the median lobe is also nicely tucked away. Median lobes should be appropriately measured at least in the initial 20 to 30 patients. You should be able to see or measure the intravesical length and also maneuverability or fixity of the median lobe. Median lobe size can be measured by comparing with the flexible cystoscopy. For example, in this patient, the flexible cystoscope used is 4 mm in diameter. So with the help of that, you can measure the median lobe length. If it is double the size of the flexible cystoscope, it is like 8 mm protrusion. So this gives a rough guide on how much of maneuverability needed for the median lobe. Let us now go through the UroLift system components. So the main implant has 3 components. The capsular nitinol tab, which is 30 mm. Then there is a PET suture. This PET suture will be connected to the urethral end-piece, which is 8 mm. The main brilliance of the UroLift comes with the adjustable length of the suture. Based upon the individual patient's prostate width, the application of the urethral tab is adjusted so that the PET suture remains taut. That is the main advantage. Even if you apply 4 implants to single patient, every implant, the PET suture size will be different because the proximal implants may be more longer while the distal implants may be smaller or vice versa. So there are mainly 4 steps. The first is releasing the safety lock. Once you are happy, once you are confident where you have to place the implant, you can release the safety lock, which is number 1. Then pressing the lock 2, which is the blue lock, will deploy the needle. Then pressing both the blue and the gray trigger pumps will release the needle back into the system. And then we create the taut PET suture and release the 4th switch so that the implant is completely released. I will demonstrate by using this film. So first unlock the safety lock, deploy the needle, and then retract the needle so that the capsular nitinol tab is nicely established in the capsule. And then as a last step, we are releasing the urethral tab. If you see, the urethral tab will be released and the PET suture will be kept taut based upon the width of the prostate. That's why measuring the width of the prostate by ultrasound is very useful. So in the initial stages, we need to practice the deployment. We have some handpieces by name clicker or trainer unit, which has no needle, so you can just practice the 4 steps by using the clicker. All the rotation should happen in the bladder, and between every implant, when you are placing that, just wait for 1 or 2 seconds to make sure that everything is done correctly. Slow and steady wins the race, at least in the initial stages. And then double pump is important to make sure that the PET sutures are nicely taut. And then you can do a cystoscope after the procedure to make sure that the implants are nicely placed to your wish. Now, coming to the deployment sequence, the deployment happens in the anterior 1/3 of the gland. This is the safest place and also a little bit thinnest place. And it gives us quite a long distance from the neurovascular bundle. So because of this, we avoid unnecessary nerve damage and also any peri-prostatic hematomas. So the implant sequence is, first we need to do the implants closer to the bladder neck. It improves the irrigation, the same TURP principle where we will start the resection from the bladder neck and go towards the veru. And the next pair is towards the veru. And very rarely, maybe I will say 1 in 100 patients may require the 3rd pair. Usually on an average, patient will require 4 pairs if not 2 pairs. If there is a median lobe will require 1 extra implant to nicely pack the median lobe also. So I will just demonstrate 1 implant insertion. So it starts with the scope in the system in the bladder, and then take the scope at least 1.5 centimeter from the bladder neck, because the needle delivery is anteriorly faced. So if we are closer to the bladder neck, the implant may inevitably go into the bladder neck or into the bladder. So at least 1.5 centimeter we need to be away from the bladder neck, and then we need to press the gland to get the necessary tautness of the PET suture. Then the needle is inserted, the retraction of the needle creates a nice capsular tab, and then we are releasing the urethral tab, which results in nicely compressed prostate. And then go back to the bladder, and once you remove your implant delivery device, there will be a sheath present, so the sheath will automatically empty the bladder. So for every implant in between, the bladder is automatically emptied. So that's a nice way. You can even do the procedure under local anesthesia. The bladder overfilling is avoided. So when you are placing the lateral lobe, the main thing is we need to look into this keyhole to make sure that the PET suture is cut at the correct time, and make sure that the keyhole is 1.5 centimeter away from the bladder neck. This video will demonstrate at least one implant insertion. So we are traveling backwards from the bladder neck at least 1.5 centimeter. Once the desired place is reached, you can see that it is 1/3 from the top. The angle is at least 20 degrees, if not more, based upon the gland. Once the angle and the pressure are adequate, the safety lock is released and the needle is released. Once the needle is released, do the double pump, which is blue and gray, which gives the tautness to the PET suture, and slightly move on the surface, and here you will get a white line. That is a very important marker. Once the white line is there, you can see there, you need to release the back suture, which releases the implant. So the same procedure is repeated again 4 times to give the best possible channel. So this picture depicts the importance of 20-degree angulation. If you have 20-degree angulation, you are getting nice perpendicular insertion of the needle, which gives us the shortest and taut PET suture. So the first important lesson is it has to be nicely compressed for 20 degrees. If there is no compression, the needle will go anteriorly. If it's nicely compressed, the needle will be perpendicular to our working plane. That's where we can achieve the maximum compression. The second main point is we should be 1.5 centimeter away from the bladder neck, otherwise the needle can inadvertently injure the bladder neck. Coming to anesthesia and procedure planning, in my practice, I prefer local anesthesia, so 5 to 6 patients can be done in a span of 1.5 hours. Patient will walk and jump into the theatre table and walk down and walk back. If the patient already got a catheter, it's better to keep the catheter for another 3 to 4 days, because the prostate will be having edema and patients won't be able to pass immediately. But if the patient is not on catheter prior to the surgery and voiding well, mostly they won't need any catheters. And initially, maybe I will say 20 patients will require anesthesia in your practice, but it's all individual. Sometimes in UK, those who are doing private practice, they do all the private practice under GA, but in NHS, they will try to do under local so that they will keep the techniques intact. The initial lift study protocol involves 10 milligram diazepam. I have stopped giving diazepam. I just give 1 gram paracetamol that gives enough pain relief and enough alleviation of the anxiety. And we don't do the catheter also. We just instill only the cold lignocaine into the urethra, which gives good urethral analgesia. This is the full procedure room setup. We will have enough amount of implants ready, and there will be one nurse talking to the patient, keeping him occupied, normal saline irrigation with a monitor, and this is the full UroLift stack system and instruments. The instruments comes in full set. For example, in European countries, you don't have to buy the introductory cystoscopes. All you need to buy is only the implants. The scopes will be supplied by the company. So the whole UroLift proficiency pathway has online education and procedural training by meetings like USICON. For example, if this is a face-to-face meeting, we thought we will do a good simulator and also a lot of training involved, and then procedural mastery by using the clinical setup. Thank you very much, and I'm happy for any questions.
without any significant bleeding, because the needle goes and then it may hit outside the venous plexus and some periprostatic hematoma or something like that.
Thank you, Dr. Somis. That is the main reason that we should make sure that the implants are 1/3 from the top and not going below the plane of 3 o'clock, 9 o'clock, where we know from the radical prostatectomy, the neurovascular bundle is mainly below 4 o'clock and below the 8 o'clock plane. So we are in a relatively avascular plane.
How many of these patients will subsequently require TURB or enucleation, and over what, how much period of time? I mean to ask how durable is this UroLift?
Regarding the durability, as of now we have data up to 5 years, and now we got the latest 7-year data. I will say the percentage of patients who may require some secondary procedure is around 8 to 7%. Depends upon the individual practice. If we take the old cohort like lift study, the percentage goes up to 10%. But now, once the development of techniques are good and patient selection is good, the durability is almost 97 to 95% for 5 to 7 years.
Is it likely that these implants migrate somewhere in bladder and form stones?
As long as the urethral tab is in the prostate, the chances of stones is nil, because there is no resistant contact with the urine. Only if the implant is in the bladder neck or into the bladder, then it can form stone. When you are placing the implant, if the urethral tab is closer to the bladder, we need to remove it straight away. We can do MRI. It is MRI conditional as per the radiology rules. You may miss a small area of 3 to 5 millimeter closer to the outer retinal tab where the imaging will be quite difficult. Otherwise, rest of the area can be imaged. There is a good MRI sequence available from Australia.
Alright, thank you very much. I think it's an upcoming procedure, and let us see how it happens in India, whether it is get accepted or not. Thank you.
Thank you.
Interesting talk.
Thank you for the opportunity. Thank you.